So STEMI with shock, what should we treat? Shock or MI? So there's always a discussion about this. I do not have any disclosures for this talk. The current paradigm that we are in, it always focuses on primary reperfusion in acute myocardial infarction, whether there is with or without cardiogenic shock. We are always in this race. I think, and especially in the United States, you might see even billboards saying that we got a door to balloon time of 19 minutes or 12 minutes. That's the lowest I've seen. But I think this craze has to stop because there is no benefit for the patients after some time. I'll show you that. So this is the reason why we are in that debate about door to balloon versus unloading is because we always were told that time is muscle. We need to open up the vessel as soon as possible. So let's look at where the data comes from and whether we are going to make any changes at all. Okay. So the biological plausibility is that if you come to from 180 minutes to 120 minutes, there is a decreased mortality. 120 to 90 minutes, again, there was a decreased mortality. From 90 minutes to 60 minutes, there was a little bit of benefit of survival. But after 60 minutes, we were not able to cut down the amount of myocardial viability or salvage or even mortality. So we reached a sort of a problem once we got up to 60 minutes and below, it's not going to make any difference. And why is that? Your reduction in door to balloon did not improve survival after this point, whether it is in patients with cardiogenic shock or without cardiogenic shock, or whether they're older than 75 or not. So the mortality remained the same from here, as you can see in elderly or anterior myocardial infarction or cardiogenic shock patients, that the mortality remained stable after, even though the door to balloon times have come down in the blue. In the red, actually, it shows the rate of mortality. Is there a persistent quality gap? What are we trying wrong, or what are we doing wrong, and why are we not able to reduce the mortality below this 5% mortality with anterior wall MI? That's what we need to understand. So patients with longer door to balloon time die because they are sick. They get, obviously, they're sicker patients coming into the lab, and most patients present to the lab 3 hours after symptom onset, and after which, if it's more than that, they have a flat part of myocardial salvage curve. And most patients also die from ventricular fibrillation, and an open artery is the best therapy for preventing ventricular fibrillation. Only up to a certain point, after 12 hours, that benefit starts dwindling down. So when this gap has been there, and we recognized it a long time ago, and whether we thought as maybe LV unloading rather than just increasing the oxygen supply, maybe reducing the oxygen demand of the LV might actually be able to benefit the patient. And that's the reason we are trying to look at this. Which one should we treat? Maybe treating the shock is much better than treating the door to balloon time alone. So why do we need to treat? We need to move this curve of LV loop, as you see the stroke work that is being done in this square, to the left side as much as possible. That will reduce the amount of workload. So this has been tested out by my colleague and friend Kapoor in the past with a occlusion of a artery, opening it up versus actually continuing the occlusion for 60 more minutes, but keeping the patient on Impella and looking at the infarct size. And I'll tell you in short that actually that showed that there was no harm that can be caused by prolonging the occlusion of the artery and with a LV unloading device such as an Impella. And as you can see, the people who had unloading had a better LV loops as compared to people who had reperfused. So these LVs are slightly dilated, much baggy hearts as compared to who had primary unloading. So I think this is a great work that has been seen, and you can see in this graph, in this picture, animal studies have shown that primary perfusion had still more necrotic myocardium as compared to primary unloading, and despite actually prolonged balloon time, door to balloon time. So this was the standard of care, in the control, whereas unloading the left ventricle with or without cardiogenic shock actually showed that the amount of release of my CKMB and infarct ratio were much lower in people who had a ventricular assist device. So I'll skip these slides because I'll talk about a human being as well, where we did that similarly. So time is muscle. Obviously, there is always a race towards unloading, but towards early balloon times. But unloading is more important now, and this is becoming a mainstay of therapies in acute myocardial infarctions with cardiogenic shock. So I'll skip this slide because of view of time. So this is a study by Pervez Miraj and presented at TCT. An unprotected left main and cardiogenic shock from the CVAD registry. That is a CVAD is an Impella based registry in the United States that we do, and I'm the PI for our center. Only patients with unprotected left main and anterior myocardial infarction complicated by cardiogenic shock were included. 17 sites contributed the patients. Primary endpoint was survival to discharge and 30-day survival. Secondary endpoint was in-hospital hemodynamics and complications. So in this study, majority of the patients are 68 years of age, 77% were male, and 36% were diabetics, and they obviously had only very few people had prior bypass surgery, and ejection fraction obviously is very low, 24% on most of them. So if you look at the time of duration, there have been majority of them, 58% were in shock for less than 6 hours. So, and very few of them are between 6 to 24 hours, and more than 24 hours were 32% of the people. So Impella, IABP pre-Impella, and the number of inotropes are mentioned here, about 1.8 inotropes pre-Impella, and inotropes during Impella is also 2.07. And we looked at Impella pre-PCI versus Impella post-PCI. The number of inotropes have been come down on people who had Impella versus actually people who did not have Impella in the beginning. They had to be on higher doses of inotropes. And so looking at actually, this is the most important slide, that actually the systolic blood pressures were better with the Impella support. Mean arterial pressures were higher with Impella support, as well as the diastolic blood pressures were also definitely better with Impella support on the right side. So the in-hospital outcomes, if you look at an Impella pre-PCI, survival to discharge was 55% versus Impella post-PCI was 18.75%. So here in that slide alone, I can tell you that the treatment of shock is more important than treatment of acute myocardial infarction, with the door to balloon times being shorter. So this is the single slide if take home. Impella pre-PCI improved survival versus Impella post-PCI in this CVAD registry. So we do recommend nowadays with all of our patients that unloading is very important, and with the cardiogenic shock, absolutely. And now this is a paradigm shift in acute myocardial infarction management, not only in people with cardiogenic shock, but also in people without shock. We actually started doing a trial called door to unloading trial. So this is a trial that based on the animal studies from Naveen Kapoor, and then a early feasibility study, which one of our centers is where I am. And we are now enrolling in a larger DTU trial in anterior STEMI patients between 21 to 80 years for first MI, and within 6 hours of symptom onset. And we randomize them either to without unloading do primary PCI, or they might be randomized to unloading and immediate primary PCI after 30 minutes. So this is a 64-year-old woman, hypertension, diabetes, hyperlipidemia, remote history of breast cancer and cervical cancer, chest pain for 1 hour. She was very nervous and crying, and she had huge ST elevations, tombstoning in the anterior leads, as you can see. The options could be multiple thrombolytics to enrollment in our DTU trial at our center. That's what we did. And this is explaining to the patient was a slightly problematic, but we did a good job. So here is our femoral axis, as you can see, under ultrasound guidance, and also making sure that the artery is big enough, and which is very important because to reduce complications. And then we did an LV gram. It shows severe LV systolic dysfunction. We randomized this patient after talking to our team, And we did the diagnostic angiogram. The right coronary is okay. Then we actually unload. We don't even look at the left coronary. We unload the left ventricle with an Impella device for 30 minutes. And then we perform the angiogram. We can see that STs are already started coming down on the EKG. And here the vessel now has has opened up with a TIMI2 flow and a 99% lesion, which is critical. We stented that with a single stent and had a good flow through that. And the patient did quite well. The final angiogram looks very good. And the patient went to the floor and STs have come down. And we kept the Impella for about 4 hours or so. And then we brought her back down to remove the Impella without any problems in the cath lab. So, and final picture also showed that before percloses that there is no problem at all with the femoral axis. So I think having a balloon support, IABP or Impella or ECMO or a tandem heart is very important in such patients. And as you can see, the next day ECG was almost now STs have come down, and she had to be given nitro for hypertension initially, actually. And then she became hypotensive, required IV fluids and pressors for 36 hours. But the CT scan showed no RP bleed or hematoma. And all of these patients undergo cardiac MRI. And she did that. And the amount of infarct actually is very minimal. And STs have completely resolved in this patient. So I think in what I would recommend is that patients can be unloaded for up to 24 hours. Whether a patient has acute myocardial infarction with or without cardiogenic shock, but absolutely with shock, there is no question that we start unloading first and open up the artery. And hemodynamic support is much more important than actually establishing a TIMI3 flow immediately. So with that, I'll stop here and I'll be more than happy to take any questions.
I have a question, please.
Yes.
Thank you, doctor, for your game-changing study, and because if it is popular and it is well established, it will be a game-changing in the world. So how many patients you have enrolled in your study?
Yeah, very good question, Dr. Pradeep Kumar. We have enrolled about 4 patients in our center. This is initial study was about early feasibility study of 60 patients. And with that, FDA has sponsored a larger trial, which is still ongoing and just started recently.
So if a patient come late, so you are unloading and simultaneously you are going to the primary PCI after 60 minutes?
Yes, that's right.
You are going to first, any case you are going to unload first.
We unload first. If the patient is not even in the clinical study, our practice here has been especially in cardiogenic shock, we unload the ventricle first. Even before we take an angiogram, we just actually look at the echocardiogram, low ejection fraction. The vessel size, femoral vessel size is not prohibitive. We actually put an Impella first and unload the left ventricle, and then actually go ahead and do PCI.
In my country, it's still not, Impella is not available, and it is a costly device. What is the poor man's Impella in my country? So can unload.
Yeah. So I think, balloon pump is still not a bad thing to do. And balloon pump and ECMO might be one of the ways to support the patient in acute, in cardiogenic shock for sure, in India and Bangladesh.
That's great.
Thank you, Sanjay. Can I ask a question?
Yes, Dr. Das. You're muted, Dr. Das. You muted yourself again. Dr. Das, you're muted. You muted. Can't hear you.
Okay, thank you.
Yeah.
Am I audible now?
Yes, Dr. Das. Yeah.
This is Professor Probir from Chittagong, the port city of Bangladesh. So thank you for your introduction into a new paradigm in management of cardiogenic shock patients with STEMI.
Thank you.
So in our patients, most of the patients coming with cardiogenic shock, still we are practicing thrombolytic therapy because of lack of this availability of this Impella and ECMO, whatever unloading procedures. Do you think it is of any help to the patient giving thrombolytic therapy, and subsequently, of course, we are proceeding with pharmaco-invasive therapy in these particular patients?
Right. Absolutely. That is great help. Even though I'm in the United States, I'm in a rural part of West Virginia, which we have a huge heart institute. But majority of the patients come here with the thrombolytics from our region as pharmaco-invasive approach. We take about 500 acute MI patients a year. About 400 of them come from with the thrombolytics from outside. So it definitely helps. There is no question. Door to needle time, door to balloon, both are important. I think the immediate revascularization by whatever means is the mainstay of therapy. However, we can get it done. So in shock, obviously, even in cardiogenic shock, you should give thrombolytic first and then ship them immediately to a center of PCI.
Dr. Kalra, this is Dr. Mohsin. Can I ask you a question, please?
Yes, Dr. Mohsin.
Actually, the majority of the thrombolytics used in our country is streptokinase. But as you know, that if you are going for a pharmacoinvasive PCI, a thrombolytic streptokinase can confuse the ACT reading during the subsequent PCI. So do you recommend using the more thrombus-specific thrombolytic like that, tenecteplase or other thing to make the life easy for the subsequent operator who is going to do the primary PCI later on in a patient of cardiogenic shock?
Yeah, I'm sure most of you are more knowledgeable than me about, we do recommend more fibrin specific, such as retavase or tenecteplase. But obviously due to cost issues and India, Bangladesh, most patients might get streptokinase. I don't think that it is anything wrong in using streptokinase. The initial studies were all done with streptokinase and concomitant use of heparin, understanding that the dose, underdose the heparin in those patients to about 12 units per kilogram and continuing it is good. Or even using Lovinox nowadays, enoxaparin 1 milligram per kilogram sub-Q could be used along with that.
So I think in the interest of time, I'm going to allow one last question from Fahim before I move on. Fahim, please.
Thank you, Ramesh. Ramesh, that was a great talk. I just have a comment and a question. So my comment is that, this is great preliminary data. The surrogate evidence that, by CMR, the infarct size is smaller is very encouraging.
Are you hearing?
But
Hello?
We still need to see the outcomes data before we put this into routine practice of unloading everyone at the time of, presentation. Now, my question to you is that biologically, the reason why patients don't do well despite opening up the artery is reperfusion injury. And we see that all the time. You open up the artery, good flow, yet the ST segments actually go up 5 millimeters instead of getting better. And so do you think that with this concept of unloading, while it's attractive, we're really barking up the wrong tree? And the real problem is reperfusion injury, and we're not really directly or indirectly tackling that. I wonder what your thoughts are on that.
I absolutely agree. And, I'm smiling because I have enrolled several patients in different trials with myocardial reperfusion injury. They all have been negative and very disappointing. But I think none of them had this approach of actually unloading the left ventricle, maybe protecting the ventricle for a little bit longer and seeing what will happen. And absolutely, you're right. This is early data. We need to wait for outcomes based on this. And we are now pushing our device companies to do a randomized clinical trial in cardiogenic shock. As difficult as it is, we need to have a randomized clinical trial for that.
Thanks. In the interest of time, I'm going to stop
Jack.
it here because I don't think we'll be able to finish all the questions.
Yeah.
A few things. I sense that thrombolysis is still a major reperfusion strategy in many parts of Asia. I think we should focus a lot more on that. I'm not certain that Impella or offloading means will come in a big way in Asia, where we can't push people for primary PCI or even IPP support at the moment. So there's a huge gap. But I like the fact that you're pushing this frontier. pushing for lower door to balloon time below 60 minutes is not the way to go. You're shown very clearly it doesn't help mortality in this group of patients. So until we figure this out,